A very good Saturday morning, everyone. Before the webinar begins, just a little housekeeping. If you have any questions during the presentation, please type them into the question box in your Zoom control panel. We will bring them up after each speaker has finished speaking. However, we are not able to hear you. We also have a short survey at the end of the webinar. Hi, my name is Julia Yatim. I'm an advanced practice nurse in this SGH Pelvic Floor Disorders Service, and I'll be your MC and moderator for this webinar public forum. On behalf of the organizing committee, we welcome you to this public forum virtually on this beautiful Saturday morning. The SGH Pelvic Floor Disorders Service is a multidisciplinary service jointly initiated by specialists from the departments of colorectal surgery, urology and obstetric and gynecology, and also gastroenterology in SGH. It serves to help patients with incontinence and other pelvic floor disorders such as constipation, urinary dysfunction, wound prolapse, and bloatedness. Too loose, too tight, or just not right? What is going on with my pelvic floor is this year's focus. I'm sure you are eagerly waiting to hear from our panel of experts from Singapore General Hospital to learn more about these issues. These are the resources for you to get to consult us. You can access online appointment system via mobile app Help Buddy or call the line as shown here. Let's kick off our webinar with the first topic. But first, let's take some poll questions and see what we know. Poll questions. Question 1. Pelvic floor weakness only occurs in the elderly and I do not have to worry about it as if I am young. True or false? Question 2. Pelvic floor weakness is often related to pregnancy and childbirth. True or false? Question 3. Pelvic floor weakness is irreversible and there is nothing I can do to strengthen my pelvic muscle. True or false? We will now wait for the responses. I'm so eager to look at your responses. Let's wait a while. It's a good weather today. Yes, do we have the responses? Yes, I'm so eager to. Oh, wow. Pelvic floor weakness only occurs in the elderly and I do not have to worry about it if I'm young. Yes, it can occur to any one of us. So the answer is false. Pelvic floor weakness is often related to pregnancy and childbirth. Let's see what our speaker is going to discuss about this. And pelvic floor weakness is irreversible and there's nothing I can do. Irreversible. Oh, actually, it is reversible. Yeah, thank you so much for the responses. Okay, let's now invite our first speaker, Dr. Jason Lim. He is a senior consultant, obstetrician and gynecologist who will share with us about causes of pelvic floor weakness and how I can strengthen my pelvic muscles. Dr. Lim, please.
gentlemen, welcome to today's SGH Pelvic Floor Disorder Public Forum 2021. My name is Dr. Jason Lim, Shao Keng. I'm a senior consultant obstetrician, gynecologist and urogynecologist at the Department of Obstetrics and Gynecology here at SGH. Today, we're going to talk about the pelvic floor disorders, and my topic would be, is it too loose? What are the causes of pelvic floor weakness, and how can I strengthen my pelvic floor muscles? These are some of my disclosures. One I'm going to cover in the next 20 minutes will include the following. I will run through what constitutes the anatomy or the supports of the pelvic floor. What are the causes of pelvic floor weakness, and what problems can it lead to in terms of this weakness? And finally, what can I do about it? Then we'll do a quick summary of what we've gone through this morning. So, what supports your pelvic floor? What is the anatomy looking like? In this slide, as you can see, our pelvis is located right at the bottom of our abdomen. And this constitutes the pelvic floor support that controls as well as support all the important organs within our abdomen itself. It would involve our bony pelvis, or the bone that lies right at the bottom of our pelvis, as well as a set of important muscles. So this is the bony anatomy, or the bones of the pelvis, namely making up of 3 sets of bones, the 2 ilium bones on the sides and a sacrum bone right at the back of our spine. And as you notice, in the middle of this bony structure lies a very big orifice, or a big hole, as you can see on my cursor here. So what happens to this hole? This hole here is being filled up by the pelvic floor muscle. It is a very big and large set of muscle that lies right at the bottom of our pelvis, and this is important for supporting all the important organs in the abdomen, namely the bladder in front where we store our urine, and in the women there's the womb or the uterus just behind the bladder, and finally there's also the intestines that lies right behind the uterus or the womb. So over time in evolution, if one believes that our ancestors came from the primates, then what has happened over the years? As you can see, our ancestors, the primates, walk on all fours, and as we evolve, we start to stand on our 2 feet. And as a result of that, our pelvis or our pelvic bone starts to rotate and tilt to what it is today. And as you can see, it becomes very horizontal. Because of that, anything that is above the pelvic bone will be pulled down as a result of gravity naturally. So these are very important supports of our pelvis, and this pelvic floor muscle serves as that important support, because without which all our pelvic organs, our abdominal organs, will be left on the floor. So what are the causes of pelvic floor weaknesses? These are some of the risk factors that can be classified broadly into the non-modifiable risk factors and that of the modifiable risk factors. Under the non-modifiable risk factors, we have advancing age, menopause transition, as well as any muscle or connective tissue disorders. These are natural phenomena that we cannot change. We are born with it. We have to undergo all these processes in our lives. On the other hand, under the right hand side, the modifiable risk factors, meaning to say that these are the things that occur along our lives that we can either adopt or we can maybe change. Take for example, obesity, vaginal parity, meaning pregnancies, cigarette smoking leading to a chronic or long-term cough, or even some form of chronic strain whenever we pass motion. All this can exert unnecessary and excessive force on our pelvic floor down below. And of course, when we deliver large babies as well. So obesity being a risk factor, is because of the fact that as we put on weight, this excessive weight exerts an excessive amount of pressure on our pelvic floor, and this is on a daily basis. In terms of heavy weights, well, besides the fact that we are lifting heavy weights in the gym on a get well, get healthy kind of regime, other situations such as, for example, when your occupation or your daily work requires you to carry heavy weights on a daily basis, this will again exert a lot of unnecessary and excessive pressure on our pelvic floor. How about risk factors, for example, straining when you pass motion? And as one starts to strain to push that hard stools out, this again exerts an unnecessary and a very excessive amount of force on our pelvic floor down below. How about coughing and sneezing? A transient cough and a transient sneeze will not result in any undue kind of pressure on the pelvic floor unless this cough or sneeze becomes a long-term cough or long-term phenomenon, and this may and will result in a lot of stress on your pelvic floor down below, because every time we cough and sneeze, we actually increase our abdominal pressures, and this is transferred to the pelvic floor muscle below. In terms of aging and menopause, these two important life-changing factors, again, these are something that we can't change, but invariably they do contribute largely on your pelvic floor weakening, because with menopause and aging, our muscles will start to weaken, start to sag or reduce in size and bulk. Pregnancy is another huge risk factor by itself, because as you can see, the location of the baby or the fetus in the abdomen with relation to your pelvic floor muscle down below. And during the 9 months of progress of the pregnancy itself, at the beginning in the first trimester, the weight of the fetus is negligible because it is still very small. But with the passage of time, as one enters the second and the third trimester, the baby gets larger, and as you can see on the red line, which denotes the location of the pelvic floor, it starts to be sagging, and because it's trying to withstand and tolerate a huge amount of pressure and stress of the fetus that's above it, and this fetus continues to grow throughout the 3 trimesters until finally it is full term or it is in the 3rd trimester. So can you imagine that this weight of the little one, averaging about 2.5 to 3 kilograms, is the additional weight that you have to carry on the pelvic floor on a daily basis in the 3rd trimester of your pregnancy. What happens at the point of birth then? What does childbirth or delivery have to do with pelvic floor? And as you can see in this diagram, if you can follow my cursor here, the arrow, this is the location in front where the bladder sits, and this is the bladder right in the middle, behind which is where the anus or the rectum is. This is the size of the vaginal opening in the non-pregnant state. But with time, it will kind of stretch, because with the passage of the baby's head, it will need to open up to allow the baby's head and body to pass through the pelvis. And in this case, how does it do so? All the pelvic floor muscles between the pelvic floor bony structure itself will have to stretch to this sort of diameter in order to allow the baby's head and body to pass through. And can you imagine the amount of stretch this has to undergo during that few hours of childbirth? And as you can see, what are the after effects of pregnancy on the pelvic floor? In the diagram as shown on the left hand side, this is the denotation of a normal pelvic floor. It is strong, it is straight, and it is horizontal because it provides a very good scaffold of support. After delivery, the pelvic floor will weaken and sag, as can be seen on the diagram on the right hand side of the picture. How do we know all this? are happening in the pelvis, because one of the known facts in the scientific literature over the many years is that the most established risk factor for pelvic floor dysfunction and weakening is vaginal delivery. And let's not talk about overseas or other literature. Let's talk about our own literature in Singapore. In this publication, we have a clinic here in SGH run by a few of my colleagues together. This is what we call the postpartum or postnatal pelvic floor clinic, whereby we follow up patients or mummies who have just delivered. And as you can see in this study, over the last 4 to 5 years of collation of data, up to about 1/4 or 1 in 4 women or mothers after delivery will experience some form of stress urinary incontinence, which means that when you cough and sneeze, there is involuntary leakage of urine. And up to about 15% will undergo or have this urge urinary incontinence, which means that when you feel the urgency to go to the toilet to pass urine, you might not be able to make it to the toilet in time, and urine will involuntarily leak out along the way. And it's about 1 to even 5 or 6% of cases, they even experience what we call fecal incontinence or flatus incontinence, which means that you cannot control your stools or your passing wind, and it comes out on its own involuntarily. This is rather embarrassing, don't you think so? So how long does the pelvic floor muscle take to recover after a pregnancy? Generally, it takes about 6 weeks, but it can take as long as up to 6 months in some cases. This is because the bony structure has been widened permanently, as you can see in my previous slides. And with this widening of the bony structure, the pelvic floor muscles and ligaments are lengthened and overly stretched, resulting in a long-term or even sometimes a permanent kind of weakening of the pelvic floor. What are the problems that this can cause if your pelvic floor muscle remains weakened as a result of all these risk factors that I mentioned in my earlier slides? Essentially, this pelvic floor dysfunction can cause urine incontinence, fecal or stool incontinence, as well as a prolapse. Prolapse meaning to say that part of your bladder or the uterus or even sometimes the intestines will flop down between the legs through the vaginal opening as a result of weakening of the pelvic floor muscle. So what are the different types of urine incontinence that it can manifest or show up as a result of pelvic floor weakness? Namely, stress incontinence, which I mentioned earlier on. When you cough, you sneeze, you jump, or even you run, there's involuntary leakage of urine. Or there's urgency and you can't make it to the toilet in time. This is part of a condition we call as overactive bladder, which means that your bladder is constantly reminding you to go to the toilet whether you like it or not. And as a result, if you do not obey these signals from your bladder, then it will overcome and overtake your voluntary reflex to control it, resulting in an involuntary or involuntary leakage of urine even before you reach the toilet in time. This can occur during the daytime or even during the nighttime because it tends to overflow. Most of the time, such incontinence after delivery tends to be transient. That means to say you do recover, but there's also a good proportion of mummies which, if you experience any incontinence of the urine after delivery, this may be a long-term issue without appropriate care and rehabilitation. How about fecal incontinence? This is another issue whereby there's involuntary leakage of stools or even unable to control your passing of wind or the leakage of wind as a result of your pelvic floor muscle being incapable of holding it in. And in terms of prolapse, this is what happens. Part of the womb comes out through the vaginal opening. This is rather uncomfortable and rather embarrassing because it kind of inhibits or impairs the way you walk. Imagine having to walk with something between your legs all the time, or even sitting down, having the feeling that you're sitting on something between your legs. This is what we call prolapse. So, We know what it can cause. Is there anything you and I can do about it? The answer is obviously yes. We try to first of all treat and identify any aggravating or triggering factors, and these are the factors that I mentioned earlier on. Any long-term cough or sneezing needs to be treated. Any long-term problems with passing or moving your bowels, such as constipation, also needs to be addressed. And finally, a problem of all affluent developed countries would be that of weight gain issues. This is something that I will again highlight and emphasize, that this is going to exert a lot of unnecessary and excessive pressure on your pelvic floor muscle right at the bottom of your pelvis with this increasing weight gain problems. What happens if your muscles are weak? What can you do about it? Naturally, in bodybuilding world, when the muscles are weak, what you can do is you build it up. You do weights, you train up your muscles, and obviously the more training you undertake, the muscles become stronger and bulkier, as shown in this diagram. Can we apply the same theory to that of the pelvic floor muscle? And the answer is obviously you can. It works in the same way, in fact. All these pelvic floor exercises or pelvic floor muscle training, some of you may know it as the Kegels exercises, has been proven in the scientific literature to be useful in recovering the pelvic floor muscle strength. Obviously, this requires a lot of compliance and hard work from you as well. And once you stop all these Kegels exercises or pelvic floor exercises and you ignore them, over time the muscle, despite whatever good it has achieved or obtained from the prior pelvic floor exercises regime, will now start to weaken all over again. Hence, this is a long-term issue that needs to be addressed, because it's just like, investments. You need to invest over long term in order to see its dividends or whatever good it can bring to you. The more you do, the more good it will bring to your pelvic floor muscles. And the role of surgery, unfortunately, do not play a very huge part in all this pelvic floor muscle weakening, particularly in the younger generation. How about in the older generation? Well, our first line recommendation would still be that of pelvic floor muscle training. And when can you do it? Contrary to many beliefs or myths, pregnancy is not a contraindication or is not an adverse factor to doing pelvic floor muscles. Pelvic floor muscle training or Kegels exercises, rest assured, do not have a negative or adverse impact on the developing fetus during pregnancy. In fact, it is highly recommended as part of the antenatal classes to start to perform and train your pelvic floor muscle. Of course, this goes without saying, after delivery, after pregnancy, this is even more pertinent. And let's not talk about ladies. Gentlemen out there, please be reminded that the pelvic floor muscle is also applicable to you as well, besides the non-pregnant individuals, as it is a perfectly safe exercise to do at any point in your life, at any time in your life. In summary, after going through all the points above, it is important to recognize that prevention is still better than cure, as I always tell my patients. We try to recognize and mitigate the risk factors that can cause pelvic floor dysfunction. I've highlighted to them in my previous slides. So take note of them and ask yourself, do you have any of these risk factors? And if you do, can you do something about them now? Early recognition and rehabilitation of the pelvic floor is vital, because the earlier we rehab the pelvic floor muscles, the faster it recovers. And in this symposium or public forum, we have been trying always to promote the awareness of pelvic floor dysfunction and what problems it can cause to all our women. The notion or the thought that has been passed down from generation to generation, saying that having some urinary incontinence or heaviness sensation down below is normal in women, especially after delivery. Well, I beg to differ, alright? Because no one should suffer in silence if you have any leakage of urine, involuntarily especially. And with that, I've come to the end of my talk. Thank you for spending time this morning with us here at the public forum. After this, I'm happy to take any questions from the floor.
Thank you, Dr. Lim, for that brilliant talk. I have a question here. If let's say I have an occupation that is laborious, heavy lifting, and then I'm still young. But then after looking at your slides, this is very educational. Will I be the next victim of poor pelvic floor dysfunction?
Thank you, Chairperson. Yes, one of the things about all this long-term carrying of heavy weights does gradually weaken the pelvic floor muscles over time. Of course, when it comes to the definition of heavy weights, there's no standardized or cutoffs in terms of the amount of weight or the duration of time that one must achieve or undertake before there's significant degree of pelvic floor weakness. That means to say the direct cause and effect relationship is not a 1:1 ratio. So to answer your question, in short, I would say that as a general advice, if your occupation or your work, or even for that matter, young ladies, right, carrying of heavy weights on a long-term basis does not bond very well with your pelvic floor muscle, obviously. So the question then would be, is there any way, perhaps in your day-to-day activities, you can actually take this into consideration in terms of trying to lighten that load, and maybe instead of carrying on your shoulders, carrying on your hands, maybe you can do kind of see some of the people out there using all these luggage strollers, pushing around rather than putting on your shoulders. So essentially, I think if there's any way you can lighten the load, it'd be advisable. But of course, if not, then probably you might want to consider doing all the pelvic floor exercises, which the next few speakers will expound on later on. Thank you.
Thank you, Dr. Lim. You mentioned about pregnant mummies as one of the factor there. Is it better to go for C-section than natural birth to protect our pelvic floor muscle?
Thank you for that fantastic question. This is a very common question that even in our the scientific world has been asking. The quick and short answer to this is that no, unfortunately, elective cesarean section does not ultimately protects the pelvic floor. Because why? Because there are many other what we call contributing or triggering factors other than pregnancy, as highlighted in my talk earlier on. So even though undertaking a cesarean section, right, does momentarily and maybe transiently protects the pelvic floor as a result of the choice of the mode of delivery, but because that 9 months of carrying the baby, as mentioned in my slide, is already a risk factor on its own that already exerts some form of pressure and stress on the pelvic floor, and coupled with other stresses along the way. For example, if there's weight gain, there's a long-term call for constipation issues, all this gradually will negate and minus off any of those protective effect from a cesarean section. So I guess besides a cesarean section, this is only one mitigating factor, I must say. There are still other factors to consider in terms of pelvic floor protection. Thank you.
Thanks, Dr. Lim. One last question that before we move on. Any other conservative treatment for pelvic floor strengthening for older kids or even for adults with poor cognition? Yes.
I suppose this is going to be a challenging issue for individuals with poor cognition or even awareness in terms of trying to, promote the education on the pelvic floor, particularly with pelvic floor muscle training. So my personal recommendation is that seek professional help, right? Because there is professional help out there, especially in our pelvic floor service, right? Whereby despite the differences in the awareness and the cognition levels and understanding of the pelvic floor, here our team of dedicated physiotherapists, our team of dedicated clinicians, and everybody here in our pelvic floor service have tons of experience in managing and handling such individuals and such cases, because this has to be done on probably a one-to-one tailored supervision so that to achieve maximum yield on the pelvic floor. And as my team of professionals in this service, they have been well versed, they have been well trained, and I'm very confident that they can help any individual out there who needs our help. Thank you.
Yeah. Thank you, Dr. Lim. I do agree a lot on the customized or one-to-one training per se. Thank you so much, Dr. Lim. We'll come back later because we move on now. Thank you.
Thank you.
Yeah. Next up, next interesting topic will be delivered by Associate Prof. Ng Lê Quat. But before that, let's see how much we know about pelvic floor tension myalgia. And you can do these poll questions. Poll questions, please. Question 1. I have heard of pelvic floor tension myalgia. Yes or no? Question 2. Chronic pelvic pain may be a result of tensed pelvic floor muscles. True or false? Question 3. Pelvic floor tension myalgia only occurs in women. True or false? You may start. This is such an interesting topic. I'm just so eager to see how much we know. This. Yes. Have the words. Oh wow, I have heard of pelvic floor tension myalgia. Right, about 80% have not heard about it, right? Question 2, chronic pelvic pain may be a result of tense pelvic floor muscles. Yes, it's true. And pelvic floor tension myalgia only occurs in women. Yes, the answer is false because it can happen to any one of us. Thank you so much for responding. Yes, now the much awaited topic. We will now invite Associate Prof. Ng Lê Quat, Senior Consultant Urologist, who will be delivering this interesting topic, pelvic floor tension myalgia, causes and treatment to release tight pelvic muscles. Let's welcome Associate Prof. Ng Lê Quat.
Good morning, everyone. Welcome to the SGH Pelvic Floor Dysfunction Service Public Forum. My name is Ng Lê Quat. I'm a urologist in the Department of Urology, Singapore General Hospital. The topic for this morning is on pelvic floor too tight, non-relaxing pelvic floor, or pelvic floor tension myalgia. Why are we even discussing this? This is because pelvic floor tension myalgia is really not an uncommon disease. It is poorly understood, misdiagnosed, or considered psychological for some doctors who doesn't understand the condition. These can present with a myriad of symptoms that straddles across various specialties, hence resulting in delay in diagnosis and leading to devastating problems for the patient. Before we discuss the disease condition, we need to understand the anatomy of the of the pelvic floor so that we can understand how the condition comes about. The pelvic floor essentially is this sheet of muscles that straddles from the pubic bone in front to the coccyx or the tailbone at the back. It supports the three main organs of the pelvis, mainly the bladder, the uterus and vagina, and the rectum. Then whole abdominal muscles as well as all the organs in the abdomen actually sits on top of the pelvic floor. The function of the pelvic floor mainly is to support the pelvic organs. It remains in a contracted state most of the time to keep yourself continent to both bowel and urine, and also in a contracted state during sexual function. However, during elimination, the pelvic floor needs to be fully relaxed to allow full elimination. This contraction and relaxation needs to be well coordinated, and full relaxations allows the patient to pass motion as well as urine properly. Our condition of pelvic floor tension myalgia is mainly in a state where full relaxation is not happening in the patient. There are two main kinds of pelvic floor dysfunction. One, where it's overly relaxed or weak that results in pelvic floor organ prolapse or urinary or bowel incontinence, which has been discussed repeatedly over various public forums. However, the other condition where there's a non-relaxing pelvic floor is rarely discussed. This results in problems of persistent contraction in the pelvic floor causing tension and pain. Passing urine or passing bowels across these non-relaxing muscles causes pain for the patient. So main symptoms of a non-relaxing pelvic floor or pelvic floor tension myalgia are difficulties or even pain during urination, defecation, or during sexual function. This can occur singly or in combination. The main urinary symptoms are that of hesitancy, where we need to wait very long before urine can start passing out. The urine may be slow, poor flow, or you need to strain with abdominal contraction and pushing to get the urine out. Because of inability to empty properly, the patient might feel frequent need to pass urine and extremely urgent to get to the toilet to pass urine. At the same time, the patient most of the time has problems with pain during passing urine, and this pain might linger on even after the urine has come out, as this is due to contraction of the muscles that persisted after passing urine. This needs to be differentiated from the more common bladder-specific pain such as urinary tract infection, bladder pain syndrome, or acute prostatitis in the male. Bowel symptoms can include bloating, constipation, incomplete evacuation, straining to pass motion, as well as sensation of anal blockage during defecation. Sexual symptoms is mainly that of pelvic pain during intercourse. Other pain symptoms include persistent deep pain in the pelvis, low back pain, or lower abdominal wall pain. I'm not suggesting that all patients with low back pain or abdominal pain in the pelvis is due to pelvic floor tension myalgia. However, this is a condition that needs to be borne in mind if other conditions have already been excluded. How do we diagnose pelvic floor tension myalgia? This is easily done on physical examination, where during pelvic floor examination in the female's vaginal examination or perectally in males, we can feel the pelvic floor and elicit tenderness along the muscles that is on each side of the pelvis. We can assess the tone, and occasionally we can feel a very tender point, which we call a trigger point, and palpation of this trigger point can reproduce the discomfort that the patient is complaining about. With that physical examination results, we can come to a conclusion that this patient has pelvic floor tension myalgia or non-relaxing pelvic floor. What are the postulated mechanisms of this condition? There are various mechanisms that have been suggested. One of that is from childhood, where the person has never learned to relax. This can be due to traumatic toilet training experience of a child, where they are punished or they are reprimanded for problems of wetting themselves or soilage when they are toilet training. There are also history of patients having previous sexual abuse causing problems of the pelvic floor tension. Other acquired mechanisms could be due to learned habits of holding urine or handling stools after episodes of incontinence during infection or during other problems like overactive bladder. There are also other conditions in the pelvis that may be painful, such as patients with bladder pain syndrome or interstitial cystitis, irritable bowel syndrome, endometriosis, such that the patient actually contracts the pelvic floor muscles like a guarding reflex to reduce the pain arising from these organs. Injury of the pelvic floor from trauma and surgery or due to the mesh or stitches on these pelvic floor muscles during surgery can also result in pelvic floor tension myalgia. So what are the management principles that your doctor will follow when you come to problems of pelvic floor tension myalgia? Firstly, we need to identify if this person has a problem of primary pelvic floor tension myalgia, or there are actually primary conditions that gives rise to pain in the pelvis and secondary pelvic floor tension myalgia. Also, we need to address the patient's psychological problems because, as I mentioned before, the condition is very rarely diagnosed and also delayed diagnosed. So the patient may have suffered from prolonged pain and distress. Hence, the psychological aspect of this patient is very important. We then go on to give the patient medications to reduce pain as well as manage the stress factor, and local therapy to reduce the tension of the muscles as well as the primary condition. So is this pelvic floor tension myalgia a primary or a secondary condition? First and foremost, awareness of this condition is utmost important, and through thorough history and physical examination, we would be able to identify if the patient has got conditions of the other organs such as the bladder, gynecological system or the bowel symptoms, and come to treat them separately so that we can eliminate the primary condition. Providing emotional support for this patient is very important. As mentioned previously, this condition is almost always misdiagnosed, and diagnoses have usually taken many months or years after several doctors before it can be made. Hence, a simple sentence such as, "I understand you, this is not a cancer, this is not imagined, and you are not mad," helps to allay the patient's anxiety and fear. The chronic pain also causes loss of function, sexuality, and even the patient's livelihood, which can result in chronic depression. This depression also affects the interpretation of pain. Next is the pharmacological management. We can start with simple oral medications for pain, such as paracetamol, NSAIDs such as Constant, or COX-2 inhibitors such as Acoxia. We also can use central conditions such as tricyclic antidepressants, as well as other medicine that is good for neuropathic pain such as Lyrica or gabapentin. Next, we come to local strategies to relax the pelvic floor. In the clinic, we will teach the patient the function of the pelvic floor and teach the patient the reverse Kegel exercise or pelvic floor relaxation exercise. Essentially, what we do is to teach the patient to contract the pelvic floor and then emphasize on the opposite, which is to relax the pelvic floor during elimination. Local relaxation strategies include warm bath, which could be in the form of a big bathtub, or little basins of warm water to allow the pelvic floor muscles to relax. Sometimes the patient is referred for trigger point massage. This is usually done by specialized nurses or physiotherapists. A trigger point is usually a tense set of muscles that's in spasm, and stretching and massaging these muscles will allow it to relax and come into a relaxed state so that it doesn't cause pain. A lot of our local patients are not in favor of trigger point massage due to its invasive nature. Hence, we have started to use extracorporeal shockwave therapy or ESWT for treatment of pelvic floor tension myalgia. ESWT has been used in the orthopedic area for treatment of muscle pain, tendinitis, fasciitis, as well as joint pain. In pelvic floor tension myalgia, the probe is placed in the perineum and the shock pulse can be directed directly into the pelvic floor without having to do a vaginal examination or rectal examination. This shock pulse causes increase in blood flow, reduces inflammation, as well as relaxes the muscles, causing relief of pain. Other management options include acupuncture, injection of botulinum toxin directly into the pelvic floor, or other treatment options such as nerve blocks and hypnotherapy is also available in our chronic pelvic pain department. Hence, in conclusion, pelvic floor tension myalgia is not such an uncommon problem. The issue is it almost always camouflages itself as chronic urinary tract infection, chronic back pain, or pelvic pain that never goes away. Hence, awareness of this condition is very important. Of course, we are not saying that every pelvic pain, every pain on passing urine is caused by pelvic floor tension myalgia. However, if the condition never goes away and after repeated treatment it does not get better, it is time to think of pelvic floor tension myalgia. Thank you.
Thank you, Prof. Ng, for that outstanding note. We have a question here. If let's say one is in a stressful occupation, does stress will trigger more of this condition?
Don't think a stressful condition on a job is what I think that's what you're trying to say will result in pelvic floor tension myalgia. Most of the time when most person have a stressful job, most of the time you tense up other form of muscles like your shoulders, your your arms and all that, your back. That's quite common. But specific to pelvic floor, it is not impossible, but it is not usually that's not a common triggering point.
There's a question here. Could this be diagnosed for very young children around, let's say, 5 years old? Can a normal pediatrician be able to diagnose this, Dr. Ng?
It's most unusual for a child at 5 years old to have pelvic floor tension myalgia. It is probably also a bit difficult to diagnose because rectal examination or vaginal examinations will be very difficult on these patients. Personally, I've got no experience with examining a 5-year-old pelvis, so I would not be able to answer that question directly. I'm sorry about it.
Right. We pick up this question here, Dr. Ng. Does dry needling help with with tight pelvic floor? Dry needling.
Dry needling, sorry.
Yes.
Can you repeat that? What I haven't read that.
Does dry needling help with tight pelvic floor? I've heard of some masturbation, but dry needling.
I'm not sure. Cannot answer that question.
Okay, thanks.
What's dry needling?
Okay. Can the shock wave be administered on yeah. Dr. Ng, next question. Can the shockwave equipment be done on the person's own without having done by the doctors?
You need to purchase that machine, which is not cheap. Yeah, so most of the time it is probably not worth buying the machine. So what our experience with shockwave therapy is we do it only once a week, and each session is only about half an hour or less, and we will do it for a course about 6 weeks to 12 weeks, and some patients may require a little bit prolonged treatment, but it's not a permanent kind of treatment. So I don't think it's worth buying this machine.
Thank you. Again, there's a pediatric question here. Is it common for children to have pelvic floor tension myalgia?
The problem with children is that a lot of times patients like to toilet train their children very early, and sometimes they develop this issue where they have learned to contract the pelvic floor muscles to achieve this fecal and urinary continence at a young age. But they may not have an issue with pain, because these children at this time really have quite resilient muscles and they do not develop fatigue and pain. So pelvic floor tension pain essentially is like someone who has not been doing exercise and all of a sudden decides to go and do a marathon. So your muscles are aching and in pain. So these children's problem, usually if it is trained from young, do not have this problem in pain. But as they get into adulthood and some other factors comes in, then this pain problem might happen. So not as a childhood as presenting with pelvic pain in that sense.
We'll take this last question, Dr. Ng. Will the pain stretch to buttock area?
Can. We do have patients whose main issue is pain over the buttock and low pelvis area. And the main important thing that we need to make this diagnosis is that when we palpate the muscles and stretch the pelvic muscles, it actually reproduces the pain straight away when we are doing it on the spot. And that is diagnostic of the pelvic pain. Of course, by itself, pain over the buttock, pain over the back can be due to also spine issues and others. But if the compression of this pelvic floor actually triggers the pain, then yes, it is due to the pelvic floor, because the muscles stretch over there as well.
Thanks so much, Prof. Ng. We have to move on to the next speaker. We'll see you later. Thank you. Right. Now, next speaker, another interesting topic. Have you all heard of pelvic floor dysenergia? Wondering how it can lead to constipation and voiding difficulties? But first, let's attempt these poll questions to concerning the topic. Question 1, the pelvic floor is made of muscles that I can control voluntarily. True or false? Question 2, constipation and difficulty voiding is always due to a structural problem of the pelvic floor. True or false? Question 3, if I know what pelvic floor biofeedback therapy is. Yes or no? So attendees, please continue with typing your questions in the Q&A panel and not the chat group. Thank you so much. Because the speakers will type the questions for those that we are unable to bring up live. Yes, we will just wait for the response. Yep. Okay, see what it looks like for the response. Go. Aha, the pelvic floor is made up of muscles that I can control voluntarily. Excellent, yes, it's true. Question 2, constipation and difficulty voiding is always due to a structural problem of the pelvic floor. Yep, so the answer is false. I know what pelvic floor biofeedback therapy is. Oh, just a 14% C, yes. Okay, thank you so much for your responses. Now let's welcome Dr. Sherilyn Fu, who is our next speaker. She's a senior consultant colorectal surgeon and the director of Pelvic Floor Disorders Service, SGH, and she'll be sharing with us on this interesting topic. Dr. Fu, please.
Good morning, one and all. Thank you very much for attending the Pelvic Floor Disorders Public Forum this year. My name is Dr. Sherilyn Fu, and I'm a senior consultant at the Department of Colorectal Surgery, SGH. I'm also the director of the Pelvic Floor Disorders Service. And today I will talk about pelvic floor dysenergia, what it is and how to fix it. I'm sure all of us have experienced constipation in some point in time in our lives. And this is defined as the difficulty in passing stools. It could be because the stools are infrequent, more than 3 days between bowel movements. They may be hard or pellet-like. Patients, you may need to strain a lot to pass stools or spend a long time in the toilet, the feeling of stools stuck at the anus or not being complete or clean after passing stools, or having no urge to go to the toilet at all can constitute as constipation. So there are two broad categories of constipation, namely slow transit constipation, which is where the colon moves very slowly. So patients actually do not really have the urge to pass stools, and they may go for days or weeks between bowel movements. But when they do go to the toilet, they don't need to strain very much. As opposed to obstructed defecation, where the colon moves at a normal speed, and the patient may pass stools daily, but they cannot really evacuate the stools well or completely, and they strain a lot or spend a long time in the toilet. So for today's talk, I will be focusing on obstructed defecation, which can be a coordination problem or a structural problem. And in a coordination problem, which is also known as pelvic floor dysenergia, the problem is with the pelvic floor not moving in the correct fashion, rather than being a structural problem of prolapse or an anatomical problem. So first, we need to know, how does the pelvic floor control defecation? At rest, the pelvic floor is important in holding up the organs, namely the bladder, the uterus, and the rectum. It also acts as a door to prevent the contents, namely the urine and the stools, from coming out from the bladder and the rectum. And when you want to evacuate or pass stools or defecate or void, this pelvic floor actually relaxes to allow the contents to come out. So in the normal defecation mechanism, the anus muscle and the pelvic floor muscle actually relaxes so that the anal canal opens and widens. The anus and the rectum also straightens out so that the stools can come out easily. And everyone needs to, of course, use a little bit of push and pressure to increase the intra-abdominal pressure to push the stools out. And during this process, the pelvic floor actually acts as a counter pressure to support the rectum from falling out. In pelvic floor dysenergia, the problem is with this relaxation. The anus muscles and the pelvic floor muscles, instead of relaxing to allow the stools to come out, they contract instead. In this video, it probably demonstrates well what I mean.
Your pelvic floor muscles are a group of muscles that make up the base of your pelvis. This hammock of muscles helps support your internal organs, including the bladder and rectum. The bladder and rectal outlets pass through the pelvic floor muscles. The rectal outlet or anal canal is surrounded by the anal sphincter, a circular muscle which you release and tighten to control the opening and closing of the outlet. The puborectalis muscle works together with the anal sphincter. When stool moves down into the rectum, it triggers an urge for a bowel movement. When you sit on the toilet, your pelvic floor muscles relax. This relaxation causes the puborectalis muscle and the anal sphincter to release, opening the rectal outlet and allowing stool to pass easily from the rectum. These muscles are under your voluntary control, meaning you control when they open and close. Pelvic floor dysenergia is a lack of coordination in the muscles during a bowel movement. Instead of releasing, these muscles either do not relax or they tighten and close off the opening. This makes it very difficult to pass stool and may result in a feeling of blockage at the outlet, passage of narrow stools, or incomplete emptying of the rectum.
So in these patients, they often find that they need to strain a lot at stools. They may spend more than 15 or 20 minutes in the toilet, and they are unable to evacuate despite all this straining, or they may feel that they are not complete. Some patients even need to use their fingers to assist with bowel movements. How common is this problem? It is difficult to estimate the incidence as the problem is often underdiagnosed. But we know that it can affect both men and women, and it is not true that it only affects women or it is only related to childbirth and pregnancy. In some patients, there is an overlap between dysenergic defecation, slow transit constipation, and irritable bowel syndrome or IBS. So how exactly did things go wrong? How did this coordination problem start? So in a survey of 118 patients with this problem, about 1/3 of them began during childhood, and about another third started after a particular event such as pregnancy, trauma, or back injury, And in the last third, about no apparent cause. About 2/3 of these patients therefore acquired this condition during adulthood. A small proportion reported a history of sexual abuse, but a large proportion actually reported frequent passage of hard stools or intermittent passage of stools. So we conclude that one of the most common causes is excessive straining to expel hard stools over time. And this could be triggered by a bout of bad constipation, or maybe even an anal fissure or painful hemorrhoids that made it difficult to pass, and therefore triggering this problem with coordination. Also, if you are at a stress or time limitation, for example, if you have a clock timer of 5 minutes and you're expected to pass that stools, it sometimes is very difficult to actively, voluntarily relax the pelvic floor and anus muscles while contracting the abdominal muscles to strain to pass out the stools. Some patients also have bad habit of so-called needing to pass stools daily and sitting on the toilet bowl unnecessarily. It is not true that you need to necessarily clear your bowels every day, especially if you do not have the urge to go to the toilet. So if a patient were to complain of constipation and were to see me in the clinic, I, as a doctor, will do these steps to actually check the anus muscles and the pelvic floor to see if it's a problem of coordination. Firstly, by putting a finger into the anal canal, I will ask the patient to squeeze against my finger to see if the anus muscles are contracting properly. And then I will ask the patient to strain and bear down as if they want to pass stools. And during this process, I will check to see if the anus muscles are relaxing appropriately together with the pelvic floor, and to see if the anus and the rectum straightens out in the normal process of defecation. If instead I find that the anus muscles tighten up and clamp up against my finger, then I would suspect that this patient has pelvic floor dysenergia. So other than just doing an examination, the other things that I would offer would be a colonoscopy, a transit marker study, anorectal manometry, and possibly defecography. I will go through these one by one. A colonoscopy is necessary because, of course, we need to make sure that there isn't actually a physical obstruction such as a tumor or a growth in the colon or the rectum that is blocking the stools and causing this constipation. One of the tests that we commonly do is also called a transit marker study, where a patient swallows a pill containing small little markers that can be seen on an X-ray. And 5 days later, an X-ray is taken to see whether all these markers have passed through the colon. If all of them have been passed out successfully, then this patient does not have constipation. However, if there are quite a number of these little markers that are left behind in the large bowel or the rectum, then this patient may have either obstructed defecation or slow transit constipation. One of the more diagnostic tests to prove pelvic floor dysenergia is anorectal manometry, or a test of the anus and the rectal pressures. So when a patient is trying to strain to pass stools, if the coordination is correct, the anus muscles should actually relax. So the red here shows high anal muscle tone, or when the anus muscle is tense, and the green is when the anus muscle is relaxing. So in a normal pattern, the anus muscle should be green when trying to pass stools. But in a patient with pelvic floor dysenergia, you can see that when the patient is trying to pass out the stools, the anus muscles contract instead of relaxing. The other type of test that we use to evaluate such patients is called defecography, which can be a special X-ray or an MRI, which looks at the anatomy of the rectum to see if there are structural problems or coordination problems of the rectum and the anus during defecation. So it evaluates the movement of the pelvic floor, anus, and rectum at rest, at straining, and during defecation. So this is a normal defecating proctogram. In other words, an X-ray or defecating proctogram that is taken in a patient who does not have pelvic floor dysenergia. The black substance is actually simulated stools, and you can see that these stools, which are in the rectum, are being expelled out completely. In a patient who has pelvic floor dyssynergia, the stools are unable to come out because this angle, called the anal-rectal angle, is very tight, and the pelvic floor muscles, or the puborectalis muscle, actually causes a kink. So this is demonstrated in this picture. Again, the black is the simulated stools, and you can see in this patient that he is trying to strain very hard to pass out the stools. However, the pelvic floor muscles and the anal sphincter muscles are clamped up and closed, and the stools are unable to pass out well. This is an MRI, also in a patient with pelvic floor dyssynergia. To orientate you, the white now is actually the simulated stools, and this is the rectum. You can see that the patient is straining very hard to try and pass out the stools. However, the stools are unable to come out because the pelvic floor is tightened up. So how do we treat a patient with pelvic floor dyssynergia? Simple steps such as using some over-the-counter laxatives can help to soften the stools, but the key word is judicious. We should not be using too much laxatives to make the stools too runny, as it is also makes it difficult to feel the caliber of the stools and to feel the stool bulk to pass out well. Moderate fiber intake of 1 to 2 servings of fruits and vegetables per meal is sufficient, and taking plenty of fluids to ensure that the stools are soft will help. This is probably easier said than done, but keeping good toilet habits is the key to the treatment of pelvic floor dyssynergia. Number 1 is to relax. If one is tensed up, the pelvic floor is also going to be tensed up and not possible to open up during the act of defecation. Number 2, go with the urge. Once there is the urge to go to the toilet, please try not to defer this urge, as once the urge goes away, it may be difficult to come back again. And when there is no urge to go to the toilet, do not sit on the toilet unnecessarily to try to strain out the stools, as there may not be, it is difficult to coordinate the pelvic floor muscles when there is actually no urge to go to the toilet. Try to avoid this problem of straining unnecessarily. If there are no stools coming out despite trying to push, my advice will be to stand up, go do something else, and return to the toilet only when the urge comes back again. Some simple maneuvers, such as just changing your body habitus and posture a bit while passing stools, can actually help. So some simple tips include putting the foot or putting your feet up on a small footrest so that your knees and legs are elevated, leaning forward slightly and putting the elbows on the knees, and bulging up the tummy while straightening the spine does help with bowel movement. How does this position help? This position, and including even a squatting position, actually helps to straighten the anus and the rectum so that the stools can come out more easily. I'll show you this little video, which may help you understand it.
When you make a deposit, it smells, Fargo. This muscle I can't pronounce puts a kink in your colon, slowing down your gold rush. You could get constipated, so you can't do the doo-doo that you do when you do doo-doos. Look what happens when you squat. Behold, that kink goes away so you can potty like it's 1999. Sorry, wrong prince. That's because our bodies were designed to poop in a squat. It's smooth, pleasant, and natural.
Other methods that we can use to treat pelvic floor dyssynergia include diaphragmatic breathing, which helps to expand the lungs and increase the intra-abdominal pressure to push the stools out. Locating and actively relaxing the pelvic floor and anus muscle to try to do this, together with taking a deep breath to increase the pressure in the tummy and to push downwards towards the anus, can help to expel the stools. Some patients actually find that using a warm shower spray or bidet such as this helps them to pass stools better. Actually, it is not the shooting of the water into the anus that helps to irrigate the stools to come out, but rather spraying some warm water at the anus does help the anus muscle relax and the pelvic floor relax to allow the stools to come out. Some patients actually help themselves by using a bit of pressure against the muscles and pelvic floor just in front of the tailbone to try and relax the pelvic floor muscle. Avoid digitation as much as possible. In other words, avoid placing a finger into the anus to try and dig the stools out, as that can cause unnecessary trauma. Biofeedback therapy is the mainstay of treatment for pelvic floor dyssynergia. And this is a form of so-called physiotherapy for the pelvic floor that retrains the muscles during defecation. It teaches patients how to coordinate their abdominal, pelvic floor, and anal sphincter muscles, and it teaches patients relaxation and evacuation techniques. It also improves the perception of rectal filling in patients with a problem of rectal sensation. There are some tools that we use during biofeedback, and this can be either a pressure monitor or EMG or surface electrodes. During biofeedback therapy, which is conducted by a trained therapist, these pressure probes or EMG probes are placed against the anus, and the therapist actually tells the patient how to relax and squeeze and coordinate the anus muscles or pelvic floor muscles appropriately. So this visual or auditory feedback is provided by the patient actually looking at the computer screen to see whether or not he or she is squeezing or relaxing the anus muscles correctly. So you can see this bird flying across. If the bird flies higher, actually it means that the patient is squeezing or contracting the anus muscles more. If the bird flies slower or lower, the patient actually is relaxing the muscles. So this gives a visual feedback to see if the patient is coordinating well. So the results of biofeedback therapy are not instantaneous. And like with any exercises or physiotherapy, gradual improvement over repeated sessions and over a period of even 3 to 6 months are expected if exercises are done consistently. Re-evaluation by the pelvic floor nurse or therapist is required to see if there's an objective or subjective improvement, and sometimes revision may be necessary. Other treatment for pelvic floor dysynergia include neuromuscular electrical stimulation, which is electrical stimulation using a probe of the anus muscles and the pelvic floor muscles to allow the patient to sense these areas better and to allow the patient to know which muscles to contract or relax during defecation. Another mechanism, another treatment that has been talked about is Botox or botulinum injection, not used for the face, but actually used at the pelvic floor muscles to try to relax these muscles. However, the results of this is generally quite dismal, and there's little conclusive evidence to show that this really works. Some patients have resorted to using acupuncture. I have had some patients who have tried acupuncture after not being successful after biofeedback therapy, and they have found some successes with this. Some patients ask, is there a role for surgery? Can we do something to relax or cut that pelvic floor muscle? Well, the unfortunate answer is no. There is actually no real surgery that works, because the problem is not a structural problem, but rather a problem of coordination. So surgery is generally not recommended. So with this, I conclude my talk on pelvic floor dysynergia, and I hope you have enjoyed it. In the next talk, my nurses, Julia as well as Eileen, will share with you on pelvic floor physical therapy as well as biofeedback therapy to tell you how this is done. Thank you.
Thank you, Dr. Fu, for the excellent sharing. Dr. Fu, we will do one question before, because we have 3 more speakers. I'm pretty curious here. Some people may not be comfortable in the toilet that is not their own, for example, outside or while traveling. And that makes them, you say, try not to hold off the urge. So in this consequence, they are not back to their own home toilet environment, but they have strong urge. What's your advice?
Well, I mean, once you have an urge, the best is to defer the urge. Of course, and also if to defer the urge, and quickly just do whatever you need to do and get out of the toilet. It is okay if the stools are not totally evacuated or you don't feel absolutely completely clean. Don't keep straining at the toilet. You can spend maybe 5 to 10 minutes, but if once done, just get up, go and do something else. Maybe when you are back in a familiar environment, maybe back home, then you can try again.
Okay, thank you, Dr. Fu. And then because of pandemic, many people are working from home, and the toilet pattern may change lah. So they're very much close to environment, and yet that will affect their symptom of having constipation or passing bowel too much. Your advice? Dr. Fu? Okay. Yes. Dr. Fu? Dr. Fu, you want me to repeat the question? Never mind, I'll take a new question. If the tool is like pellets and take a long time, the person is having IBS, does it consider as constipation?
Okay, actually irritable bowel syndrome can manifest as both constipation, diarrhea, as well as tummy discomfort or bloating. Doesn't mean that everyone who has hard or pellet stools would definitely means that they have constipation or IBS. So we need to see a pattern. If they consistently have these symptoms over a long period of time, we're talking about things like 6 months, and if it fulfills certain criteria, then we only then do we classify that as constipation, or if we have excluded other problems with the colon, then we can consider that sometimes as irritable bowel syndrome as well.
Okay, thank you, Dr. Fu. We will have some time again later for the rest of the Q&A. Thank you, Dr. Fu. Yes. Yeah. Next up, there will be 2 more interesting talks by our expert nurses. I will be delivering this topic towards your optimum pelvic floor health. I hope you will enjoy this. Thank you. Today, I'll be sharing with you on getting towards your optimum pelvic floor health. Hi, my name is Julia. My patients call me Sister Ju. The pelvic floor muscles have important roles to play in the correct functioning of the pelvic and abdominal viscera. The roles of the pelvic floor muscles are to support of abdominal pelvic viscera, namely the bladder, intestines, uterus, etc., through their tonic contraction. It provides resistance to increases in intrapelvic or abdominal pressure during activities such as coughing or lifting heavy objects. For urinary and fecal continence, these muscle fibers have a sphincter action on the rectum and urethra. They relax to allow urination and defecation. Pelvic floor disorders or PFD may be associated with some or all of the following symptoms: urinary urgency, frequency, hesitancy, stopping and starting the stream of urine, painful urination, or inability to empty the bladder. Constipation, straining, pain with bowel movements. Unexplained lower back pain or pain in the pelvic region, genital area or rectum or even hip. Pain during or after intercourse, orgasm or sexual stimulation. Uncoordinated muscle contractions causing the pelvic floor muscles to spasm. Let's clench your fist tight. Can you feel the tension? Think about a bicep curl starting with your arm straight versus starting at 90-degree bend. Okay, you can relax now. Being able to turn muscles on and off is integral to the health of the body. If your pelvic floor muscles don't know how to naturally take a break, because of this, they will constantly in a state of panic, clenching, and fatigue, which block their ability to get stronger in order to properly support you. If you have any of the signs or symptoms saying a continence, physiotherapist or specialist nurse is essential. The trained personnel will be able to identify the root cause of the hypertonicity and provide tools to help overcome this. The treatment session may involve a combination of the following: education, learning how the pelvic floor functions and how to keep it healthy can help you develop better habits. Pelvic floor exercises. These simple exercises can strengthen and stretch your pelvic floor muscles, improving flexibility and muscle strength. Pelvic floor manual therapy. This is internal massage that may be used to promote circulation, posture, and flexibility. Biofeedback. The next speaker will dwell more on this topic. In my clinic session, I will guide patients to re-educate the muscles. We need to focus on the top-down approach. It's about understanding what the body is protecting you from or understanding unhelpful habits and working from there. As a specialized nurse, I commonly use the following strategies with my patients: belly breathing and relaxation techniques. Work on calming the sympathetic nervous system. For example, mindfulness or yoga. Simple stretches. Some visualizations I use in the clinic to help patients connect with their muscles to let go include flower blossoming or maybe chocolate melting. Flowers are symbols of long life, honor, good luck, purity of mind and heart, and health. They are also symbols of temperance and fragile passion. Let's admire these blossoming flowers for 3 seconds while relaxing your muscle. Now, let's get on to pelvic floor exercises. It is to find the right muscles. Let's follow these simple steps. Exercise 1. Imagine trying to stop yourself from passing wind from the bowel. The buttocks and thighs should not move at all. The muscles you would use to retain the wind and not pass it will be the back part of your pelvic floor muscles. Exercise 2. Now, imagine you have a full bladder and you are unable to find a washroom. Tighten your front passage as if to stop a pee. Time for pelvic floor exercises. First, you need to find the right muscles. Then, perfect your technique. Hold that squeeze for 5 seconds. Take a 5-second break, then repeat. Maintain your focus, tightening only your pelvic floor muscles. Repeat the sets 3 times a day. These are important points to note. While doing the exercise, do not hold your breath. Do not push down instead of squeezing and lifting up. Do not tighten your tummy, buttocks, or thighs. On the release, think of simply of just letting go. Don't force the release. You can do the exercises during daily routines. Showering, brushing teeth, after urinating or while in toilet, or watching TV. Very little should move when you're doing PFE apart from the pelvic floor itself. Pelvic floor manual therapy. I do perform this in my clinic as I am a trained personnel. Internal trigger point massage of the pelvic floor can sometimes be helpful for tight pelvic floor muscles. This purpose and can reach further into all the pelvic floor muscles with ease by using internal vaginal soft tissue manipulation or massage to relieve pelvic pain by assessing muscles that cannot be reached by any other way. Through this physical examination and treatment, therapists can identify tightness and tenderness and gently stretch the connecting muscles. The therapy has been tested and found effective in several small studies and clinical trials published in peer-reviewed medical journals. Not everyone has been so open-minded about receiving internal treatment. Hence, comprehensive counseling and patient commitment is required. The therapist will maneuver lengthen anterior contracted muscles by decreasing periuteral tension, eradicate the trigger points in levator muscles, re-educate muscles to know range of motion, and also to evoke patients' awareness to muscle tension. The therapist will manipulate muscles to release and elongate those that are tense and shorten or to strengthen weaker muscles. Men also develop chronic pelvic pain that can benefit from the treatment, but in that case, massage is typically performed through the anus. Extracorporeal shockwave therapy is a new technology that has reasonable preliminary data, plausible mechanisms of action in erectile dysfunction and chronic pelvic pain syndrome. Ideal patient selection and treatment course is yet to be determined. We are now still doing our pilot trial. What does pelvic floor physical therapy entail? When it comes to pelvic floor therapy, it is important to be consistent to achieve good results. Some people need months of physical therapy to find relief for their symptoms, and in some cases, maintenance therapy is needed to prevent issues from coming back. Pelvic floor physical therapy can reduce a myriad of symptoms caused by pelvic floor dysfunction, ranging from incontinence to chronic pain and sexual dysfunction. If you suspect that you may be experiencing pelvic floor dysfunction, discuss your symptoms with your doctor to determine the best course of action for you. When there is no way to guarantee you won't get pelvic floor tension myalgia, you can take steps to reduce the likelihood, including eating a healthy, fiber-rich full diet full of fresh whole food, staying well hydrated, relieving yourself of urine and stool when needed rather than holding it, practicing good feminine hygiene, maintaining a healthy weight, taking steps to ensure proper posture, including exercise, strength training, and chiropractic care if required. Reduce stress and all your triggers, which can cause further insults to your pelvic floor disorders. Very often, we meet complex presentation amongst our patients, and we need to demonstrate the importance of a thorough assessment, as problems in the pelvis are often not isolated. Sharing on the pelvic floors here are: floor is the lack of knowledge. Floor is faulty movement patterns developed throughout life. Floor is accepting incorrect exercise advice. Floor is believing problems can be fixed by surgery while continuing damaging habits. Ultimately, as humans, we are hardwired to protect. If we suffer from pain or discomfort, or there is a threat of injury, our muscles will protect us. What happens if the reason to protect is no longer there, but only our body still thinks it needs to be protected? Continue the strengthening practices to restore pelvic floor health. Let's look forward to traveling. With that, I hope you have got the brief overview of this topic. Thank you. We will now move on to the next speaker, nurse clinician Eileen Ngai, who will share with us about biofeedback for pelvic floor disorders, what it is and how it can help you. Eileen, please.
Good morning to all. Hope everyone are well. Thank you so much for your interest in pelvic floor care, and thank you so much for joining us today. My name is Eileen, and I'm a nurse clinician with Gastrointestinal Function Unit at SGH. Nice to meet you. Before I begin, I would like to take this opportunity to thank my mentor who taught me all, and she's the clinical lead of pelvic health, advanced practice, physiotherapist lead of Royal Free London NHS Foundation Trust, Barnard Hospital, Miss Lucia Berry, and as well as her team. Let's begin. After having a better understanding of pelvic floor problems, let me share with you on biofeedback for pelvic floor problems, what it is and how we can help you feel better. Hope you find the topic interesting and useful. The agenda will be as follows. What are the main conditions seen? How can we help our patients? How exactly do we help you? A guide that all should follow, and let's take a look at what to expect when you come for a visit. Let's begin. We thought we knew. From young, we will be able to have bowel movements, and from young, we thought we knew how to breathe. It just came so naturally to us as they are our basic instincts. However, having seen patients, I beg to differ. In fact, even I myself, when I went for training on this, I realized, no, we probably didn't really know or might have done wrongly, and because of doing it wrongly for years, it would affect the muscles greatly and further affected us as we age, or perhaps certain factors changed us, thus problems arise. So what are the main conditions that we see? Or rather, what are the main problems seen? The main conditions we would see would be either fecal incontinence or constipation, but that doesn't mean we would treat all the patients the same or only provide similar sets of exercises to teach them. As mentioned earlier by our specialists, surgeries, other underlying health conditions, habits, lifestyle or pregnancy issues or prolapse are factors we need to take into consideration on planning the exercises for the patient. Overall, these exercises improves the whole pelvic floor. How can we help? So generally, how can we provide help or advise the patients in need, as our guide is really individualized and personalized in order to help you. We highly encourage whomever is in need of help to seek medical help to get accurately diagnosed and assessed. And when they are referred to specialists like myself, they will be assessed again, and a workout regime and further aids or tests will be planned out and discussed with them, as each individual may have the same general problem, but the help needed might still be different. Thus, it would be hard for me to share the exercises with all, as it's personalized, unlike Kegel exercises. Because once, if you practice wrongly, you might aggravate your condition. So what I would be sharing is more of something that generally all of us should adhere in order to ensure that proper bowel care is practiced. But first, I would like to share what happens when patients come to us. How do we help? Our biofeedback guide. What happens when you are referred to specialists? Basically, in short, our protocol, that is when patients are referred to us, we will look through previous tests done and history to understand your condition better. During the first visit, we will obtain more information and assess you. Questionnaires will need to be filled to further categorize the issue, and that exercises will be planned out and individualized, which caters to your needs. And lifestyle education, which I would share later, and diaphragmatic exercises would be taught as well, as it helps to increase the benefits of the exercise, as well as to help you to relax. All patients, depending on their condition, would need to attend several sessions in order to have improvement or see improvement. In fact, as a standard, you require a minimum of 3 sessions. Further sessions would depend on your needs, as additional equipment might be necessary to help your condition, as it depends on the severity, as well as taking into consideration any underlying cause that might have affected you. But all in all, one must be patient, as in order to retrain the muscles, even for patients with no other underlying issues, it will basically take at least 6 weeks of retraining to see a difference in the muscles. And on top of that, we would really need your cooperation and compliance with exercises. Otherwise, it will not be effective. In fact, during sessions, we would not only focus on physical aspect, we will also focus on psychological aspect. We understand the frustration and sadness or anxiety that comes with the problem, so we will try our best to help you cope emotionally. We will also try to understand your lifestyle to enhance the whole process, and most importantly, we will work towards your goal with you. So our aim is to hopefully keep you motivated and know that we support you all the way. As I mentioned, exercises are individualized, so it's hard for me to share, but what I can let you take home with would be the gold standards that we advise to all. What are the gold standards? Well, we should have daily breakfast, which kickstarts your bowel movement. And as mentioned, it kickstarts your bowel movement, right? So do try to sit in the toilet 20 minutes after you finish eating. You might fail to have an actual bowel movement in the beginning, but it creates a habit, and aim is eventually it becomes a norm to clear bowels in the morning, to let you clear your issues in the morning and be free for the rest of the day. Do note not to sit in the toilet for more than 15 minutes, as you want to prevent issues such as piles or worsening prolapse. When you have an urge, please do not delay it. If you delay it, this causes constipation. Ensure water intake is adequate, and exercise helps in bowel movement as well. So at least aim for 10,000 steps daily. As for diet, we would look at your food diary and advise them accordingly by comparing with your stool diary that will be provided to you. Using the Bristol stool chart, we would advise the patient accordingly to what is necessary to achieve the ideal type 3 or type 4 stools. And of course, practicing correct positioning in the toilet, which I will talk a bit more in a minute. But first, let's take a look at the Bristol stool chart, which when you come and see us, you'll be provided with one. Here, type 1 shows that you are very constipated. Type 5 shows you are lacking fiber. And type 7 might suggest an inflammation or diarrhea. It's good to take note and consult the doctor when in doubt or when it's different from your norm. Correct positioning. What we will do is we would recommend you to purchase a stool to elevate the legs to create the angle which results in a straight rectum to release the stools. And we will also actually teach our patients a mudra technique which further helps to release the stools. To learn that, you probably will have to come and see us. We will also teach our patients diaphragmatic breathing, which basically not only relaxes the inner muscles, but helps you, your overall to relax as well. Very beneficial to your whole well-being in and out. Here's almost at the end of my session. In order for you to understand your visit better, we have made a short video to let you know what to expect when you're scheduled to see us. Hope you enjoyed the video. Hope you have a better idea of what to expect and find the tips useful. Thank you once again for joining us this morning.
Thank you for the excellent sharing. We will now have our last speaker who will share with us on do pelvic floor problems cause tummy bloating, causes and treatment strategies. But first, we will try our final poll questions concerning this topic. Poll questions, please. Question 1. Tummy bloating and distension is always due to stomach problems. True or false? Question 2. Tummy bloating must be related to the food I eat. True or false? Question 3. There are ways to treat tummy bloating other than medications. True or false? Let's get going. Let's see what the responses look like. Yes. Right. Tummy bloating and distension is always due to stomach problems. The answer is false. Yeah. Question 2. Tummy bloating must be related to the food I eat. Yes. Answer is false. There are ways to treat tummy bloating other than medication. Excellent. Yes, it's true. Now, we will now call upon Dr. Andrew Ong, who is a consultant from the Department of Gastroenterology, presenting his topic. Dr. Ong, please.
Thanks, Drew. Good morning, everyone. Thank you to all of them, all of you who have stayed up to this point. I think you will hopefully enjoy this this session because I have a lot of practical tips for you guys in terms of how you manage a very common symptom, which is bloating, and also to have some kind of understanding of how to approach your clinic appointments. If let's say you go to see a GP, a polyclinic doctor or a specialist, exactly what to expect and when can you actually question whether things are being done the right way. So just an introduction to myself, I run the pelvic floor clinic together with my colleagues that you have already met this morning. I also run an irritable bowel syndrome clinic. Actually, in the whole of Singapore, there are probably only two proper IBS clinic, one in SGH and one in NUH. I don't think the other hospitals have this service because it's quite a labor-intensive service. So it is quite an important clinic in the sense that we see a lot of problems like bloating and constipation and very common problem. Okay, so let's just get cracking with the topic. So what is bloating, right? So these are some of the phrases that we might hear from our patients. Gassy, a lot of wind, you feel pregnant again. And despite it being one of the most bothersome symptoms that we see as doctors, it's actually one of the most poorly understood symptoms. So many doctors, they blindly investigate, they treat without actually knowing what they're treating. Patients are confused, doctors are confused. So I think first we need to understand what it means when you hear the word bloating. So when we talk about bloating, it is actually a sensation. Okay? That means you feel tummy being stretched and so on. That's what bloating actually is. When you see your tummy get bigger, it is what we call distension. So there is a bit of a difference. I'll talk a bit more about what the difference and why it's important. Okay, so as a patient, when you see a doctor and you're describing your symptom to the patient, I think it's important that you are clear to your doctor about exactly what you feel. Don't assume your doctor knows exactly what you're talking about, right? So if he or she doesn't ask, whether they know what you're talking about or not, it's hard to tell, right? So I've met also a lot of doctors who themselves unclear what bloating means. So try your best to explain to your doctor exactly how you feel and what symptoms you have. So now, if you ask the question, what are the causes of bloating? There's a way to easily remember there are 6 Fs. 3 of them are a bit more dangerous or more important. The other 3 are not so dangerous, but still important, right? So if we take this through step by step. So the first F is fluid, which is water. And if you have water in your tummy, that means around your organs, it's actually not a good thing. There may be something wrong with your liver, your other organs, and should always get checked. That means the doctor has to examine you, maybe do an ultrasound, but if there's water inside, it's not a good thing. The other thing is fatal tumor. Right? It sounds scary, but you have to understand that any organ inside your tummy can cause you to have a sensation of bloating. So if your liver is swollen, your pancreas is swollen, your gallbladder is swollen, whatever organ is swollen or involved, it can cause bloating, and the location can be a bit tricky because your body is not very good at deciding where the discomfort is coming from. So sometimes it can be very hard to pinpoint. Then the other F is fetus. So if your patient, if we see a patient or if you are someone of childbearing age, again, we don't want to subject a pregnant patient to radiation, to medications that are unnecessary. So we want to be sure that there is no fetus growing inside. And then the other three F's, as mentioned, are the more common ones, but also just as important. The first F is feces, which is stool. That means constipation itself can make you bloated. The other F is fat. So if you put on weight and your pants are tighter than usual, you will place more attention to that area and you are more aware of the sensations there. Quite a common thing. And the last one is flatus or wind. So when you are gassy, you will feel bloated. But let me explain to you why gas is not the answer to everything, because there is a lot of misconception about this. So to understand gas, we need to understand a few things. The first question we have to ask ourselves is, where does the gas come from? And then the second question we ask ourselves is, what actually happens to the gas in our body? So if in this picture, you can see, it's quite a complicated looking picture, but let me just take you through it. So there are two major ways that gas gets into your digestive system. That means your stomach, your intestines. Either you swallow it or you breathe it in. That means instead of going into your lungs, it goes into your stomach, right? So these are the two ways it gets in. And in general, when you are a healthy person, your body will match clearing it as much as it goes in. That means your body has a way of getting rid of the gas very efficiently. If you swallow a lot of air, your body will get rid of it. If the food that you eat produces a lot of wind, your body also will find a way to get rid of it. And so how do you actually get rid of the gas? Most of the time it is absorbed into your blood, inside your intestines, inside your stomach. But to do this, you need to have a healthy digestive tract. That means your stomach, your intestines have to be healthy, right? So some patients, they say, I burp a lot, therefore I have a lot of gas. So that is also not true. So there are three main reasons why you burp. If I pump a lot of gas very fast into your stomach, so that means if you drink a gassy drink, like you drink a can of Coke very fast, you will burp because your body cannot absorb the gas as fast as you're putting it into your stomach, right? So that's natural. That's one way. Second, if your stomach is being irritated by something, let's say you have a sensitive stomach, you have an ulcer, you can also burp sometimes, right? But usually that is associated with pain. And the last one that a lot of people underestimate is actually a lot of patients have burping as a habit that they cannot control. It's almost like you burp initially to make yourself feel better. Over time, you actually lost the ability to control the burping, right? In general, if you have burping without pain, it's quite normal. You don't have to worry too much about it, right? So that's burping. So when the gas goes in, it goes into your stomach, it goes to your intestines. Generally, most of it will get absorbed, right? But also in the intestines, you can produce gases. Your body doesn't produce gas on its own, but the food that is inside your intestines that doesn't get absorbed will get fermented by bacteria inside, and then you'll produce gas. So there will be some foods that are more prone to producing a lot of gas. I will show you a slide later that is going to be quite popular. But in general, food like beans, right? You eat a lot of beans, it makes you fart a lot. So this is why when you eat certain foodstuffs, you can have a lot of wind. Again, you eat things like oily food, for example. Oily food tends to slow your intestines down, and so makes you feel more gassy because you cannot clear the food as well as you usually do, right? So what does all this tell us? Firstly, it tells us that when you feel bloated, oftentimes it's not that you have a lot of wind inside your stomach or your tummy. Unless you have a lot of flatulence, that means you fart a lot, then perhaps in that situation, you may have a lot of gas from the food, right? But in general, most of the time, you don't have a problem with too much gas. So let me just show you examples of exactly what goes on. Why do you feel bloated? Because at the moment we say gas is not the answer, then there must be something else to make you feel bloated, right? So most bloating is either of four things. So the first one is your gut is too sensitive. That means the nerves within your stomach, your intestines are very sensitive. So even though the gas inside you is the same as someone else or slightly more, it's enough to irritate you and make you feel bloated. So that's number one. The second common thing is your gut is too slow. That means your gut has to move well for you to move the gas and also to absorb the gas. So if your gut is too slow, you will feel more bloated. Then the third is your body doesn't handle the gas well. So I'll discuss this later on. that means it's not the volume of gas. It's not that the amount of gas is too much in your body, but your body doesn't know how to handle it, doesn't know where to push the gas to. That's why it all comes to a certain direction and you feel very uncomfortable. So this is the third one. And the last one, which is relevant to this talk and the series of talks that we've had, is if at the back end, that means your anus area, you cannot clear the stools. That means you cannot coordinate your muscles properly. You also cannot get rid of the gas. And therefore, you will feel very bloated too. So these are the four main things. So we have to bear this in mind, because when we talk about the management plans later on, actually you have to target one of these four, right? You cannot not target one of these four things. So we just want to dispel one myth. So this is what I've been telling you guys. When you feel bloated, it's not that you have too much gas. So that is a wrong way of thinking. At the same time, when you have a lot of burping, oftentimes it's not too much gas. So you must get these ideas out of your mind. And this is something that we use science to explain. So it's not just expert opinions. There is a science behind this. So when you see a doctor, I think what's important is you have to, that the doctor actually has to figure out what's your symptom pattern. That means I must evaluate all your symptoms together and not in isolation. Then I will have a better understanding of what is going on. So what do I mean? So firstly, I talk about location, that sometimes where the bloating is not very useful because your body is not very good at telling us where the problem is. But sometimes it's very obvious that the problem is quite high or quite low. So for example, if you have the bloating much lower down in your pubic area, the organs that are involved is very different from you having bloating just below your ribs. Right? So you have to try and figure out where exactly are you feeling the sensation. Sometimes you really don't know because it's everywhere. The other thing that you need to know is, does your tummy swell, or is it just a feeling that that you have bloating? Because as mentioned, when you actually see your tummy getting bigger, that is what we call distension, and that is an important difference. So a classic story that a lot of patients will say is that they wake up in the morning, they feel okay, their tummy is flat, and then as the day goes on, the tummy gets bigger and bigger and bigger, and they feel more uncomfortable. The pants get tighter, and then they get really rotten in the evening, and then the next morning everything gets a bit better again. So this is very classic. This is usually a sign that your body doesn't handle the gas very well. It's not that you have too much gas in your body. So later we'll explain what you can do about this. The next thing is passing wind. So if you feel bloated and you have a lot of wind, that means you're farting nonstop. Oftentimes this is something from your diet, because you have to understand that your body cannot produce the gases on its own. It has to come out from the fermentation of food. So something in your diet is driving a lot of gas production. So you have to relook at what you're eating, right? So if you don't have a lot of wind, you just feel very bloated, it may not be that the gas is too much. It may be your nerves are sensitive and other causes, right? Then when you talk about meals, it's not so much the type of meals you eat, but sometimes the timing of the meals is also very important. So if I talk to a patient and my patient tells me that they get symptoms within minutes of eating versus someone who gets symptoms within hours of eating, the thought processes I think about are very different. The causes of the bloating I think about was also very different. So I need to establish a timing. And the last one is actually your bowel movements. So when you go toilet and you pass motion, do you feel better? Do you feel worse? When the days that are more constipated, is your bloating worse? The days that you're having diarrhea, is your bloating worse? All these patterns that we analyze actually help us make some kind of evaluation of what is going on. Okay, so I'm not going to go through this slide because Eileen went through it, but again, we use this a lot to explain, to try and understand from patient exactly what they are talking about. If not, if you tell me your stools are mushy, your stools are soft, hard, I really don't know whether we are talking about the same thing. So often we try to agree by looking at this picture and then agree exactly where you are on the chart. And so what are the other symptoms that you should look out for? Because this is something that a lot of patients are very concerned about. When you have symptoms, or is there something that is dangerous going on inside me? Very good question, very fair question. So if you look at the left, there is a word alarmed, right? So it's easy to remember. So if you do a blood test, you find you have a low blood count, there's no explanation, there is something to think about. Loss of weight, important. Ancestry, that means family history. If you have a family history of bowel problems, cancers in the family, this is important. If your symptoms have progressed recently, right, that means it has changed and it has gotten worse recently, we take this seriously. Then M here stands for melena. This is actually a type of blackish stools. That means your stools have blood or digested blood. So the color doesn't look right. Again, we take this seriously. If you are elderly, if you have swallowing problem, we take all this seriously. So essentially, if you have any of these features, right, we tend to investigate you a bit harder than a normal person. right? So you have to look out for these symptoms. Then the next question is, what should your doctor do? And this is true, regardless whether you see a GP, a polyclinic doctor, a specialist, it doesn't matter. The more important thing is you as a patient also have the right to kind of know when the person involved in front of you is not really, asking the right questions. So whether you can offer more information to help the doctor, right? So the bare minimum is the doctor should actually question you about your symptoms in detail. You cannot just ask 1 or 2 lines and expect to come up with an answer. It's not possible. Your doctor has to, the questions I told you about, the location, the timing of the meals, the change in bowel habits, all these things are very important things to establish. So if the doctor doesn't ask you, you don't tell the doctor, there's no way that they can actually figure out what's going on, right? The second thing they should do is to examine you properly. That means feel your tummy, put their finger inside your back end and actually examine the muscles and the coordination. Those are very important things. So you just have to be very careful for doctors who actually rush to try and do investigations without actually doing any of these things. Because oftentimes, I personally think it's impossible to know what's going on if you don't take a full, proper history. That means to ask the patient exactly what are the symptoms they're struggling with. Without that information, it's very difficult. That means doing a scan, doing a scope is not the solution to everything. You have to actually find out exactly what the symptoms are, right? So once a doctor has actually examined you, asked you about your symptoms in detail, then basic blood test is probably a good start. Ultrasound, endoscopy are not always a must. That means if you have very worrying symptoms, as mentioned, those alarm symptoms, I think these is a fair step to take. But a lot of times we don't really need all this, especially in a young patient, right? So we don't assume that just because you have bloating, you must do a scope, you must do a scan. It's not true. It depends on the patient symptoms, also as your age, your risk factors, and so on. So this is going to be a popular slide because when we talk about treatment, right, one of the most common questions people ask me is, what food can I eat so that I don't have so much wind, I don't have so much bloating? So there's a group of foodstuffs called, there's this thing called FODMAPs. It's just a bunch of carbohydrates. The name is very long, but what these are carbohydrates that your body doesn't absorb very well. So if you don't absorb them well, they will get fermented. And if they get fermented, they'll produce gas, they'll produce diarrhea. So a lot of these food you will recognize: white bread, milk, onions, garlic, beans. These are common culprits that even laymen all know. But some of them can be very surprising, like dried fruit. So your stone fruits, your apples, your pears are very surprising. Mushrooms, we eat a lot of these. And then we also didn't realize that they cause diarrhea and bloating. Artificial sweeteners. So you eat those diabetic artificial sweeteners, your Diet Coke, all of those things can also cause you to have very bad bloating. So the food that you want to avoid are food with high FODMAP content. So you can Google a lot of websites and you just type low FODMAP diet. Then you can find a lot of instructions, but it's not that easy to eliminate on your own while maintaining good nutrition. So if you really want to do this properly, you have to speak to your doctor who can refer you to a dietitian, because you need to find replacement for the things that you eliminate. You can't just eliminate everything. It's not healthy to do that, right? So now the question is, how do we treat patients with bloating? Mild cases of patients with bloating, you can give probiotics and anti-cramp medications, but that only works for mild cases, right? So in general, these are the 4 things that I mentioned cause bloating. So your doctor has to target one of these 4. So if your bloating doesn't go away and whatever your doctor does doesn't target one of these 4, that's probably why it's not working. So for example, the first one, the gut too sensitive. What do we do about this? We can actually treat the patients with medications that target the nerves, right? Some of these medications are actually antidepressants, but we use it not because we want to treat the depression, but because the brain and the intestines, they share the same nerves. And so we use those drugs at a lower dose to target the nerves, right? So you see a lot of medicines like omeprazole, famotidine, antacid, simethicone, charcoal. These are, I've written it here. All of these don't work, right? So if you are getting these things from your doctor and you're not getting better, it's probably because these drugs are not working, because these drugs do not target any of these 4 factors. And so you shouldn't be taking all these things long term. If it works good for you, yours is probably a mild case. But if it doesn't work for you, no matter which one you swap, it's not going to get better. So you have to target the problem. The problem often is the nerves, right? So this is the first point. The second point is that the gut is too slow, right? So when the gut is too slow, you probably have to give something to push everything along faster. Some drugs that GPs can give, some drugs are only available in a specialist setting. So you have to see to ask your doctor to try out a few of these drugs. Now, the third one is the one that confuses a lot of people, gas handling, right? So how does your tummy handle the gas, and what can we do about it? So let me show you what I mean by this. So there's a myth, right, that patients with bloating have a lot of gas inside. And some do, but many don't. But what exactly is going on? So there is something going on in your tummy that you don't realize. If I pump gas into your tummy, your body will do a few things. There's a muscle underneath your lung called the diaphragm. This is the one that singers train to sing well, right? So when I pump gas into your tummy, your body must make space for the gas. So the diaphragm will actually relax and rise. So you see on the left part of this picture, you can see that the diaphragm goes up, right? And then the tummy in front, the muscles will those muscles that you use for sit-ups, those muscles will tighten, and so the gas will stay inside your tummy. It doesn't go anywhere. So this is what a normal, healthy person have. That means that's also why when you lie down at bed at night, you don't feel so bloated, because the distribution of gas inside your tummy is different when you're standing and when you're lying down. But if you are someone who suffers from bloating, often for a lot of patients, what they have is all these muscles are not working well together. That means instead of your diaphragm rising, your diaphragm remains low. So you look at the picture on the right, you can see that the lungs are at a lower level than the one on the left. That's because the muscle doesn't rise. So your lungs remain low. And so you sometimes feel a bit chuan. You feel a bit breathless when you actually feel very bloated. It's also partially because of this. At the same time, instead of your muscles in front tightening, your tummy muscles that you use for sit-ups, instead of tightening, it's overly relaxed. And so the gas has nowhere to go, but it goes forward. So the volume of gas inside your tummy actually is the same as a healthy person. It's just that your body cannot handle the gas as well as the other person. And that's why you feel uncomfortable. You feel bloated. You see your tummy getting bigger and bigger through the day. This is exactly what's going on. Now, so the question is, what can we do about this if we see this? The problem is a lot of doctors actually don't even understand this concept. This is something that you have to be quite specialized to actually understand this. And it's actually very surprising that a lot of people don't even know this kind of reflex, right? So this is something that is very real, very common. And what we do is we actually work with the speech therapy department in SGH. We get you to do diaphragmatic breathing, which you have heard a few times, and we modify it a bit. So we get you to move your diaphragm, right? To learn how to move that muscle. At the same time, we teach you how to retighten your abdominal muscles as you exhale. And so in doing this, you're essentially reversing the problem that you saw just now. And when you do this in many sessions, you actually get better and better at controlling the bloating. That's one way. The other way is exercises like yoga, even regular aerobic exercises actually help a lot. Because aerobic exercises, when you run, when you swim, when you cycle, they actually help you move the gas along your tummy. And those of you who attend yoga lessons, you will notice that a lot of people are farting during yoga. It's not because of anything else that they eat or what, but because a lot of the positions like the one you can see here, they actually apply a lot of mechanical pressure to the abdomen to allow the wind to come out. And therefore, a lot of these movements actually are very helpful in mobilizing the air, right? So even these exercises, simple as it is, are very good at moving gas into your tummy. So, and the last one that we have is a biofeedback, right? Right. So the gut is blocked at the end. What do we do about it? So what's interesting is this study that was quite recent, right? So this looks a bit complicated again, but let me just take you through this. So the white bars are the people who responded to biofeedback. So whatever Eileen showed you earlier, that's biofeedback, where they actually teach you how to coordinate your muscles. Okay, so the white bar here are the people who respond. The black bar are the people who don't respond. And what you can see, the interesting thing is if you respond to biofeedback, it's not just your constipation that improves. Your bloating, your top left, you can see the bloating symptom. The VAS is your severity of your symptoms. Everything improves. Your bloating improves. Your stool frequency improves. Stool consistency improves. Amount of laxatives used improves. Your distension, your swelling also improves. So what you realize is that if you treat the problem area at the back end with biofeedback, there's also a lot of effects higher up for the bloating that actually the patient gets to enjoy. And that's why a lot of times we have to examine the muscles at the anus properly when we are evaluating someone with bloating. So this is an important thing again that a lot of physicians and doctors might actually miss out. It's potential area to make the patient feel better. So in summary, right, the bloating is a very common problem. I'm sure a lot of you have bloating at some point in time in your life. The mild ones, it's okay. You can get away with it. The moderate to severe ones tend to give a lot of issues. And I think what we need to understand is not due to excessive gas. We must stop thinking that way. And if you are seeing a physician, a doctor who treating your bloating, they have to target one of these things. Too sensitive, too slow, don't handle the gas well, and block at the end. If their treatment doesn't target any of this, oftentimes it's going to be very disappointing, as you will notice, unless your symptoms are very mild. Okay, so that is something that I hope you take away, so that when you see any physician, any doctor, it's okay to tell them that this is what you heard and this is what you feel should be done. And so maybe you can have a discussion about it, right? And then perhaps get a treatment plan that will treat your symptoms better, right? So with that, I've reached the end of my talk. I'm happy to pass the time back to Ju.
Thank you so much, Dr. Ong, for the interesting note. Maybe just one question for Dr. Andrew Ong. Are probiotics helpful to solve bloating?
Okay, thanks for the question. So I think for probiotics, all of you have to be very careful. The reason is the probiotic market is very unregulated because probiotics are not really a medication, and therefore they are not under the same control as a lot of the medications that doctors prescribe. That's why you can buy probiotics over the counter. So because of that, a lot of companies will claim a lot of things, and there's no way to prove it. But if you look at the quality of evidence out there, probiotics have very little effect on anything, right? That means people who say take probiotics, it can solve all your problems. That's not true. If you are fortunate enough that you take probiotics and things improve, then I think you are very fortunate. But it's very simplistic to think that just taking one pill of live bacteria can change the billions of bacteria inside your body that is causing you problems, right? So I think it's very simplistic to think that way. But the harm is not that great, and therefore, if you want to try it to see how it goes, it's not wrong. But doctors who swear by it, I don't think it's right because generally it doesn't work. Yeah.
Okay, great. Can we all call our speakers to show your put on your videos? Yeah, great. So you get to see all our experts here now. Great. Before we depart, please respond to our short survey sent to your email after this. On behalf of the organizing committee and the entire workforce, we would like to take this opportunity to thank all of you for attending this year's virtual public forum. You have been such a great audience. To the excellent speakers, thank you for sharing. Thank you for joining us, and may you have a very good weekend. I'm Julia, and I'm signing off. Wave everyone. Thank you. Have a good weekend. Yes.
Thanks, everybody. Thanks, Julia. You were fantastic today. Thank you, everybody, for attending and spending the Saturday morning with us. Have a good weekend, guys.
Yes.